Next time onwards, we'll be in time. You see, the topic for today actually is it is essentially the most basic, which is history, physical examination, and case presentation. Although in the present day examination format, long case is not there, and the importance of long case over the last few years has kind of gone into background, and there is greater emphasis on short cases. But I thought that the objective of this exercise of our learning, because I myself learn every day from such exercises, is better management of patient, better diagnosis, better management. And for that, resort to management of patient in the format of a long case is essential. Once you are comfortable with the history taking and the examination and the long case format, then you can, with practice, focus it down to a shorter period of time. Obviously, if you take, say, 20 minutes in taking history and physical examination and all that, this is actually the minimum that you would take, about 20 minutes. You cannot do that all the time in the OPD, that you spend 20 minutes with a patient in an OPD which runs into 100 or plus 100. And even if there are 4 people who are managing that, you cannot spend that much of time. But to arrive at a reasonable diagnosis and to then formulate its management, it takes practice. You just can't reduce it to, say, 5 minutes, 10 minutes. Now, in the shorter format of the examination, in which you have to be at a Tokes station, you have to go through and even in MRCUG cases, MRCUG examinations, you have to go through a scenario in a quick time, get to the point where you identify the main essential points, and from that you then build up the case or the diagnosis, and then with that the management. And therefore it is important that after having practiced a long case, then you know that what are the various features. Now in this presentation, I am going to go through rather quickly, say in 10-15 minutes, and various aspects of history taking and physical examination. And then if you have to present a case, how do you do that? I have then shortened some of those slides to, say, 8 or 9 or 10 slides. That this is how, if you have to present, you will present a case like that. And then if you want to further reduce it, you can reduce it further and condense it. So I'll start with essentially the basics, and sometimes going to basics is quite revealing. Right. History, examination, and case presentation. I very much welcome if you have any points, and you can flag or raise your hand on the net, and let me know if you want to make a comment. And if you want to add, or if you think that there is something which I am putting extra, please do comment on that and do tell me. Now, this is essential, which is called the patient identification, or previously it used to be called as clerical details. It is important. When you have to name the patient these days, you don't sound out or write down the full name as such. to for the privacy's sake, because the norms are now changing. Previously, when ethnicity was also referred to, now internationally, ethnicity or color, black race, etc., that is again something which is getting out of fashion. But anyway, the name, you would say Miss A, B, Mrs. S, N, and so on and so forth, and her age. As a matter of fact, I would want you to give date of birth. If possible, you should within that age bracket write down DOB, date of birth. And those patients in whom who can recall easily their date of birth, you refer to that. So we need to now change our format in this, that we refer to that in terms of date of birth, and that would be a kind of more reliable age status of the patient. There are many patients who come and they would say that they are 23 years of old, and if you ask them, they may have been married for 10 years. So some of those things they do not tally, and if there is a situation like that, then you need to, of course, at least show some surprise that I have asked her so many times, and I have tried to corroborate her age according to various events, but this is what my impression of her age is. Marital status, and if she's been married, and you would say married for how long, and whether they are living together, etc. That also needs to be said. I would like to add here, because this is a presentation which I took from about 20 years ago, but I would add a point about education. What's the education of the woman? Has she had formal education? And many days now in my private practice, most of the patients that we get, they have had formal education. Most of them college education, quite a few of them postgraduates. And there are very few in private practice who haven't had formal education. But in our OPDs and in our general hospitals, there still would be quite a number of patients without any education, but that is also important. So that should be, that point should be added to that. So marital status, name, age, education, marital status, and then parity, if married, of course. And parity would be 0 plus 0, or 1 plus 2, or 2 plus 0, or 2 plus 3, etc., whatever that. So far as address is concerned, it used to be emphasized that you would note down the address of the patient. It's got importance from many angles. For example, after the patient has left, you look at some point of information and you think that the treatment or the medicines which were given to her, they need to be changed, and changed for changed in a kind of urgency. Or you think that, well, that was the diagnosis which probably I overlooked. For example, you, because of some reason, you missed the diagnosis of ectopic pregnancy, and later on you realize that that could have been the reason for her symptoms, and in that case you want to contact the patient. So if that happens, then it is important that you have the contact number or the address whereby the patient can be accessed. Similarly, in case of some reports, the patient may have to be informed, and that is the importance of address. So you can dilate upon that, how address would be relevant and how important it would be. These are old things, and in every subject, in medicine, in surgery, presenting complaints and what are the presenting features, and of course they are told in chronological order. Despite having emphasized it from third year MBBS onwards, this is something which is emphasized again and again. But still, even in postgraduate examinations, or when we have case discussions or case presentations, some of these features sometimes lag. And then Second is history of presenting complaints, what we call as history of present illness. It is better to say history of presenting complaints or present pregnancy in case of an obstetrical, because the obstetrical gynecological history would differ slightly from general medicine history. In general medicine, we would say history of present illness or presenting complaints. But in obs-gynae, I would say history of presenting complaints or history of present pregnancy. So it starts from there. Now, if a woman has presented with features of, say, parity was 0 plus 4, which means she has had 4 miscarriages, 4 abortions, and it's a case of recurrent miscarriage. And you, how do you start the history? And if she has come with a pregnancy and an ongoing pregnancy at an early stage, say she presents with an amenorrhea of 7 weeks, and she gives history of previous 4 miscarriages. So how do you start? Do you say that she has had previous 4 miscarriages? No, that would be part of her later history or obstetrical history. But you would start that the woman had her last menstrual period on such and such date, and then after she missed her periods, either she had a test done herself, or she got it done from the lab, or she saw a doctor, and or she had an ultrasound whereby the pregnancy was confirmed. So that is something which needs to be established. But don't start with gestational amenorrhea, that there is history of gestational amenorrhea. First, you have to refer to the last menstrual period, and then you establish that there was some kind of diagnosis of pregnancy, either by a pregnancy test or by ultrasound or whatever. And in the meantime, if she also has certain features of early pregnancy, then you would present that. So you start from there and then go on with, depending upon at what stage of the pregnancy you are making this presentation. Now, it could be, let's take the example of a woman who presents at 32 weeks, and she has an overly distended abdomen, or you find that later on examination, or you find that she has a lot of edema, or you find that the woman is in distress. So therefore, from that point onwards, you will, taking account of her pregnancy, you will look at how she has come to up to this stage. And it will again start from LMP. She had some antenatal or not, or she didn't have an antenatal when she started feeling fetal movements, etc. So go along with last menstrual period and onwards to the present point, and that would be how you would describe her pregnancy. Similarly, gynecological history, if a woman, say 46 years of age, she presents with heavy menstrual bleeding. In that, it would be important to say that the woman was having regular menstrual periods with average flow till, say, November 2023. And in December, when she had her periods, which were early, late, or on due date, those periods were heavy, and she bled for not her usual 4 days, but she bled for 10 days, and the bleeding was heavier compared to her previous loss. It was accompanied with passage of clots, and she also experienced pain. So in that case, giving a little bit of background, it will be important because to establish when her symptoms started, it would be important that previously she was having normal, regular, or routine menstrual cycles, but in December, from December, and then in January, she also had heavier bleeding like that. So this is how we need to establish, and giving a background of the picture, and then the start of the complaints. So this will be the history of presenting complaints. And after having detailed about that, then medical and surgical history. Actually, in obs-gynae, there is no past history as such. All histories are bracketed in certain compartments. So medical surgical history, if she has had history of in previous pregnancy, she has had gestational diabetes, or there is history of raised blood pressure, or she has had gynecological surgery or general surgery procedure like appendectomy, that should be mentioned in that. And family history, which is of relevant features, and then personal and social history, specific habits and other things which, or history of drug intake, you can add a history of allergies. That's also important. Allergy to certain medications, or if they are sensitive to, say, penicillin group or augmentin, or some of them they are sensitive to NSAIDs. So you mentioned that. In medical surgical history, of course, you also make mention of the points like if there is history like autoimmune, something suggestive of autoimmune disease. I'm not saying that in every patient you would do that, but it is something which would be relevant, and you would then make a point of that. Similarly, in family history, if it's an obstetrical case, a history of twins, that will be relevant. Family history of diabetes and hypertension, that must always be mentioned. Family history of, say, ovarian cancer or CA breast, because those are the things which run in families, and they come handy when we have to formulate the management of the patient. Now, in family history, you will, someone who is presenting at the age of 25 with pregnancy, in that you do not talk about family history of CA breast. But if there is a woman who is, say, in her 40s, and you are considering hormone therapy, or even some of the other, she is to undergo, say, hysterectomy, and then you will take into account about the preservation or removal of ovaries, and therefore then you that kind of or that point in history comes handy and becomes relevant. Gynecological history has two components. One relates to menstrual history, and then the others, there are other those three components given on the other side. So you do mention menarche, menstrual cycle. If her menstrual cycle is now different from what she used to experience previously, then you will say previously her menstrual cycle was this, but since such and such time it's like that. Or till the age of 25 she had regular menstrual cycle, and she says that 2 years back or 3 years back, since then the menstrual cycle has become sporadic, or the cycle is longish, or the bleeding is infrequent, whatever. So if it is different, if it is the same, then you say that she always has had menstrual cycle like that. The amount of blood loss. So menstrual cycle, it has to be described in those days, number of days bleeding. She has regular menstrual cycle of 7/30, 7/28, or whatever number of days. So you say with average loss, with excessive loss, with scanty loss, and then associated symptoms. You do not have to mention or name the headings, but you go in a flow like that the patient started menstruation at the age of 13 years, having had a regular menstrual cycle of 7/30 days with average loss. She never experienced any associated symptoms, and her last menstrual period was on 29th of January 24. So this is how you can describe the menstrual history. Then in women who are sexually active and those who are married in our society as such, and have been married for some time, contraceptive history is important, whether they have used it or not. And if yes, then what kind of contraceptive? Barrier method, natural, what is called the so-called physiological method, or intrauterine device, or whatever, it should be mentioned if they have used contraception. History of cervical smear, whether it was taken or when was it taken, and how frequently she has had cervical smear in her reproductive life particularly, and any gynecological operations. Yesterday, I had a patient in the clinic, 75 years old, unmarried lady, who gave history suggestive of, or it was said that she had total abdominal hysterectomy. and she presented with excessive discharge vaginally, which was uh, watery, but smelled bad. When I did her ultrasound, I found that my impression was that she had a uterus. Although, because of that history, there were other ultrasounds which showed that there was a mass in the pelvis behind the bladder. It was referred to as a mass behind the bladder. And she also had an MRI, which also said that there was a mass. But I thought that it was the uterus because it had a relationship with the vaginal canal as well. Now, you see, there was something which I did not do before I placed the ultrasound probe on the abdomen, and that was inspection of the abdomen. After I observed that mass, which I thought was uterus, after having removed the transducer, ultrasound transducer, then I started examining her abdomen. I could not see a phalansteal scar or lower transverse scar, and I didn't see even a midline scar, which would have substantiated TAH. But I did see a small right paramedian scar, which was half of the scar was above the umbilicus, half below, right paramedian scar, about 1.5 inches long. Now, that scar was not appropriate or would not have been enough for hysterectomy. And therefore, I then referred the woman because she, in my opinion, still had the uterus. I referred her for a second opinion on ultrasound. And I did mention that I suspect that she has the uterus. So therefore, it is important that you go into the detail of that gynecological operation if she has had and incorporate that. Obstetrical history, summary of obstetrical history is you mentioned the number of pregnancies that she has had and parity, those pregnancies which were carried beyond the viability and those which ended up in miscarriage, number of live boys and girls last born and last abortion. Again, this has to be said in the summary, and the details of it's still better. I would say that for training residents, it is important that they go through that table format of obstetrical history. They practice that so that they become familiar with that. This is the table that we usually used, and I have added to this. Here it is parity, stillbirths, neonatal deaths, preterm, abortion, ectopic, alive, male, female, multiple gestations, malformations history, yes or no. But for each pregnancy, 1, 2, 3, 4, 5, 6, date, when did she deliver? It was a domiciliary delivery or a hospital delivery. Domiciliary is at home. Pregnancies duration, you would say full-term pregnancy, 33 weeks, or premature labor, spontaneous, induced, normal, or any complication in that. How was the purpurium? And the baby alive, stillborn, gender of the baby, and weight of the baby if known, and what is the present status, alive and well and healthy, etc. So this is the kind of history that should be placed, and then you do not have you start from number 1, 2, 3, 4, 5. You just may give history depending upon the time, etc. But having practiced this format of history, that helps you in having a better assessment of the patient's status. This is this we can come to later on. These are the risk scores or risk factors which will influence the management. And so after the history, then we go to physical examination. In physical examination, general physical examination, physique, height, weight, you would say average physique, or a tall lady, or a lady with average frame, or with a lady appearing to be overweight, but of course you will give her weight exactly as such. Pulse, blood pressure, temperature. I have shadowed a little bit because we generally do not take temperature. I haven't seen. Do you take temperature? You don't. No, the temperature is generally taken by the nurses. But if you are in the clinic, if you do take, if you mention, then you do take the temperature. But generally, we do not take temperature. And but then after general physical there, so better would be that if you have the facility to measure the height, you would give the height in so many centimeters or 5 feet and inches, and weight in either pounds or kilograms. Then general pallor, jaundice, orodental, thyroid, accessible lymph nodes, edema, breast, spine, extremities. So these are the points about which you will make a mention. Systemic examination, generally, you must go through the movements of this. Cardiovascular system, pulse is of course part of that, blood pressure is part of that. Then at least you should know where. I'm not very familiar with that, but I would advise all of you to have a physician confirm that you know how to palpate and how to auscultate, particularly the heart, and where to do that, and how to differentiate between first and second heart. Respiratory system, you must also again make a move to auscultate the chest from back, and ask the patient to take deep breath at that time, and at least keep the stethoscope on the chest till she has inspired and expired at least once or twice, so that it is not only a formality. And don't forget to put the stethoscope in your ears. Apart from CVS and respiratory system, other systems as such, you need not go into neurological examination. Abdomen, we will be palpating anyway, because that's part of our territory. So, and extremities have been seen on general physical examination. Therefore, cardiovascular system and respiratory system, they become relevant to our abdominal examination. In it would be different for obstetrics and gynecology. I'll go through this a little quickly. There will be inspection, palpation, and auscultation. And when you talk about inspection, you don't have to say on inspection, but you would say that abdomen is enlarged if scaphoid, or it is protuberant. So it is enlargement or distension. There are any scars, pigmentation. This is what you realize on inspection. On palpation, height of fundus in terms of weeks or centimeters. How to do that? Please do learn that, how to put that tape measure on the abdomen, which end would be placed at the pubic symphysis and which end would go on to the top. Lie of the fetus, and also make a mention of what is your impression on which side the back of the fetus is. Presentation, and then position of the, whether it is well settled into the pelvis, or it is floating above, and or if it is relevant at that time. For example, at 28 weeks or 30 or 32 weeks, you don't have to say anything about the position. This is something which becomes relevant in later weeks of pregnancy. And an assessment of on palpatory method of the amniotic fluid amounts, like that. So this is palpation. And then auscultation, you must mention location of fetal heart, whether it is below or above, on which side of the umbilicus it is. And after having at least listened to that for half an hour, or feigning to listen for that for half an hour and counting, you must tell the rate. In gynecological, there is inspection, palpation, and then percussion also. In cases of masses, if there is an abdominal mass, you would percuss it downwards to make a differentiation between mass which may be sometimes, rarely, retroperitoneal mass, and particularly if it is occupying most of the abdomen with large mass. So that is the relevance of percussion. And also in cases where you would suspect that there may be ascites, so shifting dullness, etc., that has to be. Therefore, percussion is part of that. Auscultation in abdominal gynecological examination is not something which one would do. This is not really part of that. So you can strike out auscultation here. Again, shape, enlargement, scars, pigmentation, general palpation of the abdomen, which should follow that path from the left iliac fossa going up to the left hypochondrium and then the epigastrium and then down to hypogastrium or suprapubic region, then to the right iliac fossa and then upwards to the right hypochondrium. So that fashion, it should be light general palpation. And if there is a mass, then we refer to the size of the mass in terms of weeks of gestation, that it corresponds with 18 weeks of gestation, or it is 24 weeks pregnancy size mass, which is a little above the umbilical, so forth, so on and so forth. Similarly, regular, irregular, it is more towards left of the midline. Consistency, it is firm, it is cystic, and mobility from below upwards and from side to side, and if there is any tenderness. These are the 5 points which in relation to the mass ought to be mentioned. And in quick, so percussion is, as I said already, auscultation, question mark on that. And then pelvic examination. You see, pelvic examination is again something which many of us have relegated to rather infrequent times for doing pelvic examination. We don't do it in most of the instances. And there is actually a question whether you should be doing pelvic examination in all women or not with gynecological symptoms. Of course, someone who's come with pregnancy issues, in that pelvic examination is not required until and unless you want to, at the later part of pregnancy, you want to have an assessment of the bony pelvis, or if there is any leaking or bleeding, etc., which would warrant a pelvic examination. But in gynecological patients, do you do pelvic examination in all women, or do pelvic examination in those who have symptoms which would warrant a pelvic examination? But first, let's go through the movements of local examination. Actually, you see, in gynecological examination, abdominal examination also is local examination. So, well, you can say local examination will be only of external genitalia. Because what you want, and part of the pelvic examination is bimanual examination, and therefore I would say that it should be referred to as pelvic examination, which is, it is got two components, which is inspection of external genitalia. So you make a comment about external genitalia, that they are normal formed and there is no lesion or there is no swelling, etc. And then speculum examination, part of that. Now, speculum examination, do you do it before bimanual or you do it after bimanual? That is also, there should be a justification for doing it before, or if you do not do it before bimanual, then a justification for doing it afterwards. Now, and then bimanual examination. On inspection of speculum before bimanual. All right, we will take that up. So good, right? So inspection of external genitalia, and in that the labia should be separated in the anterior part to visualize the vestibule, to see the urethral opening, and that is the part which is called a vestibule. And also then the introitus and the areas of the Bartholin's glands openings. Bartholin's glands ducts, Bartholin glands ducts opening, which is in the posterior, which is around at 5 o'clock or 7 o'clock area. And and many would say that when we come to palpation, that you should palpate that area with the finger and thumb also, to feel whether a Bartholin's gland is palpable or not. And then speculum examination. Speculum examination, in that you would have visualization of the cervix. How does it look? And you should be able to describe it, whether it's nulliparous, doesn't has any lesion on that, or you just say normal looking nulliparous cervix. Some and you can see that in a woman who has had previous 3 cesarean section with no attempted vaginal delivery. And you also would make a comment about the vaginal walls, that they know they were normal looking, or they were uh, inflamed, or they appeared reddish in color, which possibly is because of inflammation. And discharge, because there are always some secretions in reproductive age women. So you would refer to that as normal discharge, because it is normal discharge. And then you should also know about the composition of this discharge. Where does this come from? And if you think that it is abnormal, then you should be able to describe that it is thick, white, creamy, or cheesy discharge, or it is watery, milky discharge, or it is blood stained, or it is brownish in color. Similarly, cervix, if it is multiparous cervix, or there are Nabothian glands which are visible on that, or it has irregular surface, you can say that it indicates chronic cervicitis, or if there is ectopy. Please resist in now referring to this as erosion, because the word erosion, that evokes quite a few unpleasant or rather frightening impression in women's mind. So therefore, we must refer to that as ectopy. And then on bimanual examination, I'll tell you what I felt day before yesterday. I did, what was I going to do? I was going to do a diagnostic DNC probably. Yes. And a woman who was bleeding heavily. And my impression on bimanual examination was that the uterus was normal in size. But when I passed in, after dilatation, I passed in the sponge forceps, I found that the cavity was more than 10 centimeters long. And that made me think about doing that bimanual examination once again. And then I found that the uterus was a little larger. So even, and I think that I have a fair idea of doing a proper bimanual examination, but still I was proven wrong. So this is to emphasize that when you need to have practice of this, as residents, you must take the opportunity of doing bimanual examination when possible, particularly in women who are going to have abdominal hysterectomy, or even laparoscopic hysterectomy. In those, you should volunteer to catheterize the patient, and after having catheterized the patient, you should then do bimanual examination and have a mental assessment of what the size of the uterus is, what is its position, how it is moving, etc. And when the abdomen is open, then you can correlate your mental assessment of that size of the uterus, position, etc., and the movement when you directly see it with the abdomen open, or by the or through the laparoscope. So that would that's kind of artificial intelligence which will help you formulate your impression of touch with your fingers with that visual assessment. So you will have a good idea of how your palpation corresponds with the visual assessment of the uterus, its size, position, anteverted, retroverted, anteflexion, retroflexion, etc. And then its mobility from side to side, from before backwards a little bit. And then also the fornices, particularly the lateral fornices. These days, because of the so wide availability of ultrasound and our resort to that, getting a back seat, the pelvic examination. But still, I think that it is important for us as clinicians to be familiar with that, to have a good idea of how we are going to do to assess the uterus. And many a times, a woman who is complaining of lower abdominal pain, it is important to see whether it is related with uterus or not, because when you are doing that and you are moving the uterus or you're moving the cervix from side to side, which will stretch the appendage on the opposite side. If you are moving it towards left, the appendage of the right side is stretched. So therefore, you would know on which side she has any tenderness. If she doesn't have any tenderness on the movement of the uterus, then some other cause have to be looked for. But therefore, it is important to do that pelvic examination. And then fornices. Do you palpate anything in that or not? And finger stall is when you withdraw your fingers, you must have a look at that. What kind of discharge it was carrying out, or the examination has resulted in any undue bleeding or spotting, etc. Investigations are baseline urine complete examination. You should be clear about that, that you would, when you mention that, you should mention that urine complete examination, CBC, blood sugar random, and blood group. These are the baseline investigations. And you can add a little bit relevant if, whether you would want to do thyroid TSH or not. But I would say that this is the baseline group of investigations which all patients should have. And then specific investigations which you think that in that particular circumstances or in that particular case, depending upon the history and the findings on examination, you want to have that examination on blood, or it's an ultrasound, imaging, X-ray, etc., or whatever. So those investigations you will write there. So now, when you have to make a presentation, we come to that. You can have either these two components in 2 slides, or you can have in just 1 slide, right? So our presentation slide number 1. This would be presentation slide number 2 or 3 if you have given that the previous information on 2 slides. This will be slide number 3, 4. ये फिर मैंने इसको रिमूव किया था, ये फिर भी आ गया ऐसे। ये पुरानी स्लाइड बनी हुई थी। ये चलो कोई नहीं, इसको बर्दाश्त करो। ये general physical examination, these 3 components. This is slide 5, 6, 7, pelvic examination 8, and investigation. So generally your presentation should comprise of these 9 or 10 slides. And after this, the next one would be a summary of the case, which should be in 5 to 6 lines. So this is how I'll share it with you on WhatsApp group. So you would have then next time onwards, you would make your presentation according to this format. Any comments and questions from the participants on the net, please?
Sir, I have one question. Do we
Sure.
need to ask regarding blood transfusion in a patient like of cholestasis, or any other history in which the blood?
You see, there are so many things that you can ask or you may have to ask, but if there is a problem or any issue which would be related with the previous blood transfusion, do please ask about that. For example, if a woman says that in her last pregnancy, at the time of delivery, she had excessive bleeding, of course, that will be a relevant point in which you will ask whether did you receive any blood transfusions? Or if there is, say, she has hepatitis C, or that would be there. Or if the woman's blood group is negative, RH negative, then it will be relevant. Or if she has presented with heavy bleeding over the last few months and she appears to be anemic, that would be relevant. But otherwise, as a definitive or essential component of history taking, I don't really think it is required.
Sir, like I had one case of UV prolapse. So my examiner, I asked the blood transfusion history. The patient does not had any history of vaginal discharge or the bleeding. So my examiner said, what is the sense of asking this question in this case?
I guess I would also
I was
actually.
just completing the template.
No, I also would ask if there is a patient who has got uterovaginal prolapse, and I too would ask you if you had inquired from the patients about blood transfusion, that what is the relevance of blood transfusion in this one? Do you have an answer to that?
No, sir.
So therefore, in
Sir, I
those
just wanted to complete the templates at the headings of the history. That is why I asked.
No, you ask only if it is relevant. There are so many things which might become relevant, you see, or it is just like asking, have you had HPV vaccine? Now, this is not something which is common in our environment, giving HPV vaccine. So therefore, asking about blood transfusion, if it is not related, is not really on.
I think.
अस्सलाम वालेकुम जी, डॉक्टर साहब भी आ गए।
Assalamualaikum.
मैं तो गुड मॉर्निंग कहने वाला था।
Good morning.
इस्लाम ते छा गया है पाकिस्तान में। इद्दत में निकाह किसी मौलवी ने उसके खिलाफ बयान नहीं दिया, किसी मौलवी ने उसके खिलाफ बयान नहीं।
नहीं जी, वो उन्होंने ये इसलिए किया कि सबको इस्लामी जो मसाइल हैं उसके बारे में भी इल्म होना चाहिए।
नहीं, अब तो सऊदी अरेबिया के मौलवी साहब ने कह दिया कि डिसीजन गलत है।
अच्छा, हाफिज साहब ने कहा कि नहीं कहा?
हाफिज साहब,
अरे मैं तारीफ पढ़ रहा था सैफॉक के, वो कोर्ट शो है। वैसे तारीफ तो तेरी हर वक्त ही होनी चाहिए थी।
हाँ,
मैं खैर रुबीना तक मेरी आवाज नहीं पहुंची।
नहीं पहुंच,
नहीं बिल्कुल पहुंच रही है।
हाँ नहीं, वो उधर तो दरमियान में कट गई थी थोड़ी सी, इसलिए मेरा ख्याल है वो वो पूरा सेंटेंस नहीं सुन सकी कि सैफॉग के ऊपर रुबीना की तारीफ हो रही।
अच्छा, मुझे वाकई समझ नहीं आया।
हाँ, ये
मतलब तेरी इतनी तारीफ होती है तेन पता नहीं चलता।
सर, आपकी मेरी मोहब्बत तो पुरानी है ना। अब आप तारीफ करते हैं तो मुझे लगता है आप अपनी मोहब्बत में कर रहे हैं, पता नहीं जेन्युइन है भी क्या नहीं है।
मैं तो जेन्युइन कर रहा हूँ, पता है दूसरे कैसे करते हैं।
Yes, that's true.
ठीक है सर, ओके।